How do we improve our operational and commissioning practice to meet the diverse needs of people in Devon? Do we treat people differently based on age when assessing their need for social interaction? Key facts. People aged 18 to 64. 51% of service users in Devon say they have as much social contact as they like. For people aged 65 and over, 43% of service users in Devon say they have as much social contact as they like. Key points. We spend more per head on services such as enabling individualised support and day opportunities on 18 to 64-year-olds than on those over 65. Main points from the age discussion. Do not stereotype. Just because someone is over 65, it does not mean their need for social interaction has reduced. Likewise, younger people should have their need for social interaction recognised in age-appropriate ways. Isolation is ranked 16th out of 83 on the list of reasons for referral to the Young Devon Counselling Service. A truly person-centred approach to individual support should be taken regardless of age. Staff need to be reminded of the importance of supporting social interaction as a key part of prevention, which can help decrease dependence on formal services. Recommendations. Work out how we check that we are addressing social isolation equally, regardless of age. Ensure practice guidance and training encourages a challenge to age stereotyping. Raise awareness with providers. Why are so few safeguarding concerns raised about people from Black and minority ethnic communities, or BME communities? Key facts. In Devon, 0.83% of concerns are wholly or partially about people from BME communities. For our statistical neighbours, 2.12% of concerns are wholly or partially about people from BME communities. Key points. Areas with larger BME communities tend to have proportionately more service users from those communities. Is this because they engage with them better? The term BME covers many communities with differing needs. Main points of the race and ethnicity discussion. A lack of safeguarding referrals could be due to a lack of overall engagement with BME communities, so as part of a wider issue. Which BME communities have the lowest referral rates? There's a limited understanding of what adult safeguarding means, not just between BME people. We want to avoid using safeguarding processes inappropriately, so take care with messages about referrals. We need to be aware and challenge assumptions that all BME families look after their own and are not affected by geographical mobility. Be prepared to challenge harmful cultural practices, but avoid practice hysteria when issues like FGM, female genital mutilation, hit the headlines. Social care has become more personalised. Services which target support at BME people are spread more thinly, with reduced reach. With less collective activity, printed material such as leaflets cannot be relied on. There's anecdotal evidence that direct payments sometimes paid to the male head of the family in some communities, so depriving female service users or carers choice and control. Recommendations. Further investigate the headline BME safeguarding referral rates in comparison with statistical neighbours. Carry out more detailed work to understand which BME communities have lowest referral rates. Consider how best to engage those communities on social care issues in a proportionate way. Raise awareness with providers. Run management information reports to check who receives direct payments in BME families. Check if BME engagement is adequately covered in recruitment to the Safeguarding Adults Board Community Reference Group. How well does our assessment, commissioning and provision take account of sexual orientation and gender reassignment? Key facts. LGBT people have significantly higher levels of depression, anxiety and self-harm, and significantly higher rates of smoking, drug and alcohol use. Social isolation is a major health factor amongst LGBT people of all ages, which can be compounded by Devon's rurality. Older LGBT people are less likely to have children and more likely to live alone. Key points. Use the LGBT Plus Toolkit published in 2017 and developed as a result of the local LGBT health needs assessment. There are also resources developed to help social care become LGBT friendly. Main points of the LGBT discussion. Sexual orientation is at the core of someone's identity. The effect of not being respected can result in insecurity, isolation and unhealthy lifestyles. Is social work practice as sensitive to sexual orientation as it is often stereotypically assumed to be? What about wider social care assessment by other staff? Diversity is growing rapidly and will not go away. Is the social care market responsive to this? The world has changed in terms of how people meet one another. Is digital interaction replacing traditional safe meeting spaces and fueling isolation? Recommendations. Further promote the LGBT toolkit produced by Devon County Council. Review social worker and social care assessor training and guidance. Raise awareness with providers. Add positive LGBT plus case studies to the Proud to Care campaign. Promote Age UK Safe to Be Me toolkit. Promote the DCC LGBT staff network to the independent sector. How well do we take religion and belief into account when assessing needs, commissioning and providing support? Key facts. Only 29% of adult social care service providers said they have done work to meet needs relating to religion and belief. Yet 63.1% of people say they have a religion or belief. Key points. Ageing is a journey which includes a spiritual dimension. The spiritual dimension focuses on meaning of life, hope and purpose. Main points of the religion belief discussion. Do we know how sensitive our practice really is to the needs arising from religion and belief? How does assessment recognise and capture belief? What happens when a young person of faith has to move into residential care? Do we ensure residential care provides access to worship? Likewise to faith-based funerals. Do we support families in ways that enable them to attend places of worship? Staff need to be trained to be curious about and sensitive to religion and belief. Do not underestimate the role faith-based communities can play in helping people support themselves and others in combating social isolation. Needs arising from religion and belief are not negotiable. Recommendations. Check that our practice guidance and training is fit for purpose to address faith-based needs, i.e. it's okay to be curious. Make sure we are recognising and using faith-based sources of community support. Raise awareness with providers. Do we take the impact of welfare benefit and other changes properly into account when assessing the needs of disabled people? Key facts. Between 2010 and 2017, households with a disability score of 6+ lose 10% of net income on average, while those with a disability score of 0 lose just 0.1% of income on average. Key points. In recent focus groups, disabled people were often uncertain whether services were provided by the NHS or local authorities, or which agency provided the source of income. Main points of the disability discussion. We must see the individual, not the label of disability. Assessment of needs must be personal. Employment is really important for self-esteem and sense of purpose, as well as income. Having a disability makes life more expensive, so the impact of any reduction of income is amplified. The outcome of a social care assessment and provision should be seen in the round, taking on board the wider circumstances surrounding the person. There is a disconnect between district councils with housing responsibilities and the county council responsible for social care. Are disabled people signposted to the right sources of support at the right time? Do social care staff understand welfare reform? Providers need to be more aware of the purple pound purchasing power of disabled people in the social care marketplace. Recommendations. Check how joined up DCC and district councils are in terms of advice and information. Check how well briefed social care staff are on welfare reforms so that knowledge gaps can be plugged. Raise disability awareness amongst providers. Collective recommendations. A high priority for adult social care. Promote equality issues to providers through the Provider Engagement Network. An Equality Reference Group working party has been set up to deliver this. Run similar awareness raising with other parts of DCC.